I'm going to talk to you about the future of emergency care. But first, since this is TEDxHarvardCollege, I'm actually going to tell the undergraduates in the audience about something that you're going to get in the mail. So about 5 years after you graduate, you're going to open your mailbox. It's a physical box. It's full of paper. It'll be outside of your door. There's no reason you would have used one to date. And in this mailbox, you're going to find a red book. In this red book, you'll be able to read about all of the accomplishments of your amazing classmates in preparation for your 5th reunion. And as you thumb through, you'll read about promotions, companies started, fortunes made, marriages, and a number of other things that your classmates will have done. If you thumb through too quickly, you'll miss a small section at the end of the book, which lists the names of the classmates of yours who have died since they graduated. It turns out that young Harvard graduates die from about one of 3 things: mental illness, extreme sports, and a third cause that's no less tragic, but perhaps more surprising. And that is car accidents, which are often sustained when traveling in developing countries. Now, some of you, after graduating, will want to save the world, and that may require travel outside of Cambridge. As you're packing your bags, I want you to imagine what your mothers are thinking as you prepare for your trip to Latin America, to sub-Saharan Africa, or to Asia. If your mothers are anything like my mother, there will be a long and fairly specific list of concerns. And on that list, there might be things like malaria, or dengue, or maybe even Ebola. Chances are, what will not be on that list is car accidents. And that would be one of the few instances where your mothers would be wrong. It's not just your mothers. Most of us, when we think about global health, we think about vaccinations. We think about controlling the spread of major epidemics of HIV or tuberculosis. Sometimes we think about improving food security or improving water sanitation. And there's a reason we think about all these things. Efforts in those areas have been some of our society's greatest accomplishments that have saved literally millions of lives over the past few decades. But those successes make it easy to forget about the car accidents and the pneumonias and the heart attacks and the diarrheal illnesses and the million other ways that people in poor countries die. Those things have quite a few elements in common, but one of the key ones that I want to talk to you about is the fact that they're very difficult to prevent, and so they have to be treated. Now, one way to think about this is to think about a country like Sweden. Sweden is a country that has invested for decades and decades in primary care, prevention, public health, and all the things we think of as important for the health of the population. And that's been extraordinarily successful. To give you an idea of the scope of these efforts, there's an effort right now in Sweden called Vision Zero, which aims to completely eliminate fatalities from road traffic accidents by the year 2020. All of these efforts have been very successful. And yet, in Sweden, people still have heart attacks, and they still have pneumonia, and they still fall down stairs and break bones. And when they do, they still need emergency care. Now, you can imagine if people in Sweden need emergency care, people in poor countries need that care even more, but they're not getting it. Some of the research that I've done over the past couple of years has been an effort to collect a series of data about what happens in emergency rooms in developing countries. Now, some of you will be thinking, great, a large academic multinational collaboration to tell me that what happens in emergency rooms in developing countries is not that good. And that's a justifiable reaction. Many of you can probably imagine what things are like in those places. I didn't bring any slides because as I was going through pictures of patients and doctors in emergency rooms in poor countries, none of them really captured what it was actually like. Some of them captured the crowding and the chaos. Others let you see the dim lighting and maybe made you think that things weren't quite as clean as they ought to be. There are some close-up pictures of patients' faces that show a variety of emotions: pain, fatigue, despair. And some of them show more unpleasant things that I don't even want to talk about. What none of those pictures show is the fact that these events, these personal dramas, could have happened any day in almost any country in the world. It's not pictures of a specific catastrophe, a specific famine or war. It is the everyday reality and the everyday tragedy of emergency care in poor countries. Our data have a lot of the same problems as those pictures, which is that they don't tell stories, they don't illustrate the families and the losses, but they do allow us to zoom out and get a global scale perspective of what actually happens in emergency settings in poor countries. And so we can draw a couple of conclusions, and here are the highlights. The volumes of patients seeking care are enormous, hundreds of patients per day in most ERs that I studied. Outcomes are not good. Illnesses are of very high acuity. To give you an idea of the magnitude, in some ERs in sub-Saharan Africa, 1 out of every 5 children that are brought in by their parents will actually die in the ER in front of a doctor who either doesn't have the training or the resources to save that child's life. A lot of international organizations and donors and even national governments have very little interest in funding emergency care. And part of me understands that. There are 1 million competing priorities in global health, all of them underfunded and all of them urgent. So what is it that makes emergency care different? Part of what makes emergency care different in poor countries is actually the same thing as what made emergency care different in this country. Those of you who have watched the TV show know that emergency care in this country actually sprang up in places that didn't have a lot of spare money lying around on the table, places like Cook County in Chicago or LA County. Even in Boston, the real innovations in emergency care didn't come from Harvard. They came from Boston City Hospital. Now, we've caught up, and we do pretty well now too. But the reality is that most of the playbook that we use to deliver care every day was written in settings with very limited resources, and where that limitation was actually an opportunity to use components of the system and get more out of them, make them more efficient, faster, and better. Some of those innovations are actually fairly fresh in my head since I worked an overnight shift last night in my emergency department at the Brigham and Women's Hospital. And so I'll apologize if my talk is making you as sleepy as I feel. But I'll tell you a little bit about some of our tricks. So here's one. We don't see patients in the order that they walk in to the ER. We have very strict triage protocols that mean that patients who are the sickest come back right away and bypass the waiting room entirely. We saw a woman last night who was brought in by her family when she was found unresponsive in her bedroom at home. Within a few seconds, we'd done an ECG and diagnosed a major heart attack. And that let us set in place a series of protocols to get the blockage in her coronary arteries opened within 90 minutes of her arrival in the emergency department. When we identify serious infections, not with imaging, just with a physical exam, maybe a blood pressure cuff, we make sure that the antibiotics and the fluids get off the shelf and into the patient within 1 hour. None of those things require massive infrastructure investments or new programs. They simply tweak and tune existing components of the system and get more out of them. Those little innovations are more than just tricks and tweaks. These things have actually translated into major declines in death rates for heart attack, infections, and a range of other conditions over the past decades in this country. And those are the same things that can dramatically change outcomes in poor countries. Our research has identified a number of easy, low-cost interventions that could start changing outcomes in emergency rooms across the world tomorrow. Things like improving communications among providers, improving triage and patient flow through the emergency department, even interventions to better supervise and train junior providers. All of these things take existing components of the system and rearrange them to get better outcomes and drive performance. When all of those components come together, what you get is a system that's resilient, a system that adapts, and a system that works every day. on busy days and on slow days. It works for everyone, whether they're rich or poor, whether they have cancer or heart disease. And it even worked on a day 2.5 years ago when I walked into my afternoon shift in the emergency department on the day that turned out to be the day of the marathon bombing. That's a day that I won't ever forget. And for a lot of the people that I saw, it was the worst day of their lives, without question. In a lot of other ways, though, that was a day just like any other day in the emergency department. A lot of people came in, they needed care, they got care, and the system worked. So I'd like you to think about emergency care the next time you turn on a faucet. Think about the fact that when you turn that knob, you know that there's going to be water, that you can regulate its temperature, and that if you want to, you can drink it. There are a lot of parts of the world where there are no such certainties, not when it comes to water, and certainly not when it comes to emergency care. By 2050, I think we need to change all of that so that everyone, no matter where they are, no matter who they are, if something terrible happens on the worst day of your life, someone will be there to take care of you. Thank you.